Well, it truly is a pleasure to be here to talk to you today. I was lucky enough to come to the Personal Trainer Conference last year and talk. And it was just a great experience. My beginnings are really, as Brad spoke to, as a personal trainer. I ran a exercise testing and prescription side of a physical therapy clinic, working in a skilled nursing facility, an extended care facility. It was an outpatient orthopedic facility, so I have that rehab background. I went on and got my master's degree and got hired at a community college and ran a 38,000 square foot facility that included a sport performance complex. I created a sport performance program for 10 teams, 160 athletes, where I had 10 strength coaches that I oversaw all the development of the programming. But more importantly, I tried to translate that information, that professional knowledge, into the science, questioning what was being said by those golden tiered individuals that maybe didn't have the professional experience that you have. I enjoyed working with strength coaches out in the field, talking to the personal trainers, doing personal training. The entire time I was at Arizona State University, I was doing personal training. Not for charge, but that was part of who I was. I ran a facility. I ran multiple facilities. And I would do personal training, anywhere from 16-year-old entry-level students to, we were open to the community, so I had upwards of 91, 92, 93-year-old individuals that would come in and work with us. And they would come back year after year. Because they loved the facility, loved the fact that we had personal training as a part of who we were. So I've got lots of ABCs behind my name, but what I want you to understand is I'm first and foremost a professional, right? I still do personal training. I still work with athletes, even though my professional designation is now Dean, right? Dean of Research, Associate Dean of Research. So I get to oversee research. And I'm trying to bring in people that are interested, just like you, to my university to further the field. So we can be very scientific in the way we approach personal training. And that's what we're going to talk about today. An evidence-based approach to personal training for the aging adult. You know, we have an aging society. Colleague and friend Jim Hessen last night told me 10,000 individuals become of age every day. Every day, 65 and older. Think about the ramifications of that, and what's the problem with our society, first and foremost? We're physically inactive. What percentage of the population engages in resistance training at any one given time during their life? If we were to take a snapshot today of our society, how many people are actively engaging in resistance training? Yeah, somewhere between 20 and 25%, depending on what numbers you look at. That's abysmal. Physical activity guidelines for the United States shoot for 30% as our goal. We didn't meet it for the 2010 guidelines, but we're still trying. You are the people that need to be guiding the wheres and the what-fors by engaging those active individuals, active elderly individuals, into resistance training. And I'm going to present a program a little bit later on, and I'm going to ask you to take off your fitness center hat just a little bit, because I'm going to present a program that isn't weight intensive. It isn't equipment intensive. Why? Because sometimes we need to start at the beginning. We need to start by engaging them in a comfortable environment with exercises that they feel comfortable with, and then working from that paradigm. So when we get there, I ask you, I understand. You know, I work with athletes, I do Olympic lifting, but I'm going to present a program that's very rudimentary compared to maybe what you've been hearing about. So how many of you have utilized the term evidence-based practice and kind of consider yourself an evidence-based practitioner? How many? That's good. I can tell you about 2 years ago, this was a novel term in our field. We really didn't consider ourselves evidence-based practitioners. So I'm going to talk to you today about what is it, because now the term's being thrown out all over the place. So I want to really explain what evidence-based practice is, so we're all on the same page, and then talk you through some of the steps of how to become an evidence-based practitioner. You get to decide. What area are you going to become an evidence-based practitioner on? I want to recognize that you're all here. You know, you're at this conference. You're sitting in this section. What does that tell me? It tells me that you are taking the steps to become an evidence-based practitioner. But I'm going to challenge you to maybe do a little bit more on your own. Do some other things that will help build the scientific aspects of your personal practice. And then I'm going to provide an example utilizing some information. Brad Schoenfeld, Dr. Mark Peterson, and I wrote a book chapter on resistance training for the aging adults, and I'm going to share some of the information. It was an evidence-based approach. So I'm going to share a little information on that book chapter as well. So what is evidence-based practice? It's utilizing, if you sat on Brad's session on squatting, he talked about utilizing an evidence-based approach for squatting. You know, is there enough evidence to justify deep squatting? Well, that needs to be asked in every aspect of your exercise, testing, and prescription practice as well. So it's incorporating the best available evidence. How much evidence is out there? How much can you really sink your teeth into that evidence to really tell somebody unequivocally, this is what the science says, and this is why I'm going to utilize this technique? It's a systematic approach to the training of clients based on the current evidence, and again, it's also from peer-reviewed research and your professional experience. Your professional experience fits into this, and I'll take a step back and explain how I got to where I am. When I was a first-year master's student, it was about the time of the ACSM position stand came out advocating single-set resistance training. You guys remember that position stand? And one of my professors stood in front of the classroom and said, hey guys, all you need to do with resistance training is one set of every exercise, 8 to 10 exercises, 8 to 12 repetitions, done. And I'm sitting in the back row, and I raise my hand and I go, excuse me, I was an athlete, and I don't think one set of anything would have been enough to justify the benefits that I accrued over my 15 years of resistance training. He said, nope, evidence shows one set is all you need. And if you read the position stand very clearly, it says anything above and beyond that may have benefits, but they're going to be marginal, and it falls within the law of diminishing returns. So I questioned him, and I kept pushing the question to him. I don't believe it. My personal experience is overriding what you're telling me scientifically. And his response to me was, prove it. You prove it then. So I did. Set about on a course of research study to question that thought process. Is there anything that's driving you crazy in the profession right now? That maybe a professor or a colleague or somebody, a fitness professional, has told you that you're questioning. You know, there's a lot of talk about CrossFit, insanity. Are there areas of that that need to be studied? And I would say yes, absolutely. We need to look at the risk for injury, overtraining, the metabolic effects. What are some other areas? How about the opposite end of the spectrum? We talk about periodization. There's myriads of periodization schema out there. Linear periodization, undulating periodization, concurrent periodization. We need to do a better job of understanding what the logic is behind those and try to apply scientific principles and scientific evaluations. And I've been doing a little bit of research on periodization as well. But I ask you, find an area that you're passionate about and become that expert, somebody that other people can look to for information. And the evidence-based practice is based on a needs analysis. So if you have a specific question you're trying to answer, what are the needs of the individual client that you're working with, rather than society at large? We need to differentiate what we're doing based on the question that we're asking. So what is evidence-based practice? It's systematic. We're not blindly following experts. Don't trust what I'm telling you up here. Maybe I'm throwing in some caveats that aren't true. You need to find the information yourself. I will tell you I'm not purposefully putting anything, trying to get anything by you. And I've done my best job of analyzing the information, but don't take it just because I have a PhD doesn't mean I'm the end-all be-all. In fact, I've debated with many other PhDs about various aspects of the research. Why? Because we have differences of opinion. Research only tells us this much, right? That's why strength coaches always argue we're one step behind. We're one step behind the strength coaches. That's okay, right? Use the evidence to build. You know, I listened to Juan Carlos Santana yesterday in his band program out there. Great stuff. Is there any evidence to show that what he was prescribing will lead to significant benefits? No. But that's okay, right? Learn from it, but let's do some research to justify that type of programming. I love the use of bands, right? So don't base it on a few casual abstracts. It's another problem that we do in science is we have one or two abstracts that pop up and we go, we change our whole paradigm based on this new research, right? We need to take a look at the research body as a whole. It's a continuous process. I can tell you my early research was flawed. It wasn't flawed globally, but there were some methodological issues with some of our early meta-analyses that didn't lead, even if with reanalysis, and didn't lead to differential results. But I understand there were some methodological issues. I recognize that. We could have done it better. But what do? I look to other people's meta-analysis on dose-responsive resistance training, and guess what? Similar findings to what we found. So that bolsters our area. And then keeping an open mind. As Brad stated, is there room for CrossFit? Are there some areas where CrossFit could be beneficial? Absolutely. If you don't think so, you're kidding yourself. But what we need to do is probably do a better job of training CrossFit individuals so they're utilizing better technique, reducing the risk of injuries, and doing some things programmatically that can make it a much more beneficial program. Sorry, I don't know why I'm picking on CrossFit. Just Brad started it. Where's Brad? He started it. So searching for the evidence. Professionals shouldn't just simply search for the evidence. They must search for the best evidence. Search for the best evidence. And you guys understand what the best evidence is, right? We talk about the difference between a meta-analysis and a systematic review and a randomized control trial versus my personal opinion or observational studies. There's a difference. So when you're reading the literature, you need to be very thoughtful. How big was the sample size? How well did they control the studies? Did they recognize or report their limitations? Be very thoughtful when you're reading research. Don't just read the abstracts. It's easy to read the abstracts. We all do it. If you're going to be passionate about it, you're going to be evidence-based, you need to get in and learn a little bit more from the information than just reading the abstracts. And again, I'll use that ACSM position stand. I would now state that that position stand, in my opinion, was flawed. But at the time, it was the best evidence out there. A huge body of exercise professionals looked to that position stand as the end-all be-all, right? So continue looking, search for the best evidence. And then recognize that there's experienced professional reasoning. You get to use your experience. Do I use my experience in the research that I conduct when I'm interacting with doctoral students, when I'm interacting with master's students to guide them in their research? Of course I do. I hope that's what makes me a better scientist, is that I have professional practice. And I have strong opinions based on my experience with athletes, with the elderly, with kids. We won't go there. That's for another lecture. So let your professional reasoning fill the gaps. I think that's a good take-home message in terms of what your experience is. Use the science and allow that professional experience to kind of fill in the gaps. Look at the practicum sessions here. Use the science, but then your professional practice to realize what the strengths and limitations of those might be. Recognize that we need to use a needs analysis and talk about specificity in evidence-based practice as well. I'm lucky enough, I'm a consultant for the U.S. Army. I do a lot of work with firefighters in the Metro Phoenix area. I've also worked with collegiate, university, professional athletes, and then with seniors. Is programming going to be the same across the board? Absolutely not. Can we use some of the same techniques for each of these? Can we use the same principles? Sure we can. But again, understand that because I'm going to talk about one thing, the needs analysis isn't going to apply across the board. So evidence-based practice is a 5-step process. I'm going to talk you through that process now. Developing a question, finding the evidence, evaluating the evidence, incorporating the evidence into practice, and then reevaluating the evidence. It's an ongoing process. So developing a question. Here's my first research question. Does performing 3 sets of an exercise produce superior results in overall strength gains for a moderately trained group of individuals over 8 to 12 weeks? That was my first question. So the population, recreational trained athletes, intervention, resistance training, comparison, single versus multiple sets, outcome, upper and lower body maximal strength, and then 8 to 12 weeks was the time frame. Look at those definitions and realize that each one of those has limitations based on it. Right? So this is the only thing that we can really talk about when we're trying to apply those principles. So what did we find? Is there a difference in the dose response between a single and multiple set resistance training programs? And the answer is absolutely. And it's dependent on the different individuals that we're training. The black line would be trained individuals. We got trained individuals here. This is 1 set. This is 3 sets. This is 4 to 5 sets. You tell me. And this is how effective it is. It's called an effect size. How effective was that dose of exercise? Well, as you can see, we're just above 1 here. We're above 2.25 here, so it's twice as effective going from a single set to a multiple set resistance training program. Same thing for your trained individuals. Single set, 5 to 6 sets. Single set for an athlete, 8 sets for an athlete. But what I want you to note, and this was very clear for me when we started analyzing these results. What do you see across this line right here? Do you see the similarities? And what that tells you is to have a resultant change in the overall strength, 1 set for an untrained individual is as effective as 4 to 5 sets for a trained population and 8 sets for an athletic population. It's a dose response. As we progress in our training experience, obviously we need a greater stimulus if we want to have continued alterations in our overall strength. Okay? So that's the question, and that is our answer. So what's the question you want to ask? Step 2, find the evidence. For the evidence I'm going to share with you for the aging adult resistance training program, I looked in Ovid, EBSCO, PubMed, Cochrane Review, and Google Scholar as the search engines that I used to search for the evidence. The first 4 are more library-based searches. The last one, Google Scholar, is the one that all of us use. And don't kid yourself, even if you are a scientist, we all use Google Scholar, right? It's okay. That's okay. But if you want to find a little bit more robust evidence, you probably need to go into those different search engines. But this was the technique we utilized, as we used 5 different search engines. We looked for peer-reviewed articles based on evidence-based resistance training for older adults. I found 1,200 articles. And I reviewed all of them, 1,200 articles. It took me a long time. My chair has a permanent crease in it now. I had to get my prescription changed on my glasses. But in the final analysis, there was 100 articles that we could utilize for the overall exercise prescription. 2 co-author experts, Brad Schoenfeld, 1 co-author, Dr. Mark Peterson, University of Michigan, School of Medicine, research fellow, 2nd co-author. 60 years of professional experience. We brought that to the article. That's important. And then it was reviewed by an editor and 2 outside reviewers additionally. Step 3, evaluating the evidence. So what? So I found 100 articles that were applicable. Well, we graded the articles based on this categorization. Randomized controlled trials, randomized controlled trials with a limited body of data, non-randomized trials, and then expert opinion, A through D. And there's different grading categories out there, so I ask you to just take a look. There isn't one that's better than the other, but be consistent in your rating of your articles. And then step 4 is incorporating that evidence into practice. This is the fun part. How do I use that evidence? So let me ask you a question. I showed you that athletes need 8 sets of exercises per muscle group to optimize their resistance training program for resultant strength gain. Do all my programs have 8-set programs? Absolutely not. How long do you typically have for a group of college athletes if you're going to train them? You're lucky if you get them an hour to an hour and a half, 2 to 3 days per week. Can you do 8 sets per muscle group in that time frame? Absolutely not. So again, that's where that professional experience comes into play. I had to design the program based on the time constraints of those athletes. And not all the athletes were at the same level. Some of them couldn't tolerate that 8-set program, even if I had the time to give it to them. And then step 5, reevaluate the evidence. New evidence is always happening. It's always occurring. There's researchers out there. There's people that are performing studies. So keep abreast with the current research. Keep reading it. Keep coming to conferences. Maybe next year somebody's going to get up here and tell you that CrossFit is the way we need to train our seniors. I don't know. Could happen. Let me give you an example, though, of how I feel that there's a disconnect. There's a disconnect in what's being published in the research and what we as personal trainers and strength coaches are doing. How many of you still do static stretching prior to your exercise training protocols? How many of you? Raise your hand, because I'm going to pick on you. That's okay. I'm not saying that you shouldn't do that, but what I will tell you is the evidence is showing that we need to be doing more dynamic movements rather than static. Is there a place for static stretching? Absolutely. Absolutely. But 75% of D1 coaches are still doing static stretching. I would argue that the evidence is out there showing that there's a force and power production decrease by doing static stretching. Does that necessarily lead to an increase in injury? Is there any evidence out there that shows that static stretching reduces the risk of injury? No, not by and large. We can't say absolutely. Static stretching versus dynamic, which one's better for reducing injury? We can't. But what I can tell you is that research shows that by doing a dynamic stretching protocol, we can increase force production, we can increase athletic ability, and we can probably prepare our athletes to do the movements that they need to do for their respective sports, because you can design the dynamic warm-up specific to that individual or that team. And if there's an individual need, you can always address that with that individual athlete. So why is there a lag in what we're doing professionally versus what is being espoused in the literature? I don't know. Yeah, some of the people won't let go of that. I will tell you, personal experience, you guys will laugh. I'm the head sport performance director at a college. I oversee all of the strength and conditioning. I developed the program, I developed the facility, I got all the coaches on board. It was my program. I got called in front of the president of the university because I took static stretching out of the pre-exercise routine. President of the university. Doctor, it was female, she wasn't impressed. Dr. Alvar, what the hell do you think you're doing not stretching your athletes? I remember when I had PE 700 years ago, we did static stretching. So I had to explain to her the scientific rationale behind why we're doing what we're doing and showing that, yeah, we can, and I have shown with those athletes, beginning of the season, end of the season, guess what? What happens to range of motion? Increases in range of motion without doing prolonged static stretching. Did we do some static stretching? Absolutely. If I saw a tightness or some issues, we would do it after. If we had an extraordinary workout, maybe one day and they were a little flat during their practice, maybe we'd do some static stretching after the practice. But for the most part, we didn't do a whole lot of static stretching. Resistance training can help range of motion as well. So if you're doing proper resistance training programming, there probably isn't as great of a need for static stretching as well. Okay. So, how am I doing? Man, I am so long-winded, I apologize. We'll try to move, we'll move a little faster in this. So developing the question that we came up with for, and again, I'm just using this as an example. What are the evidence-based guidelines to provide a synthesis of the current literature for a progressive resistance training program to maintain health, function, and fitness for older adults? That's our question. So what did we do? PubMed, Medline, Cochrane. Keywords: resistance training, strength, hypertrophy, power, progressive resistance training in older adults. So if you want to go and do the search, those are the keywords that we utilized. Very replicable. Step 3, evaluated the evidence. So what did we do? Looked at every one of those articles and graded it. Is it good? What are the tenets of the articles? How much evidence was in the article? And then I want to share a little bit of background of why this is so important. I told you about the expanding growth area of aging adults, but I also want to talk to you a little bit about low levels of muscular strength and functional impairment, dynapnea. How many of you have heard that term? It's a relatively new term. And dynapnea, what is it? It's basically a loss of muscular strength and power that leads to the inability to do the activities of daily living or your functional, being able to live a functional life. There's some impairment. That's our definition for dynapnea anyway. And then we talk about all-cause morbidity and mortality and cardiometabolic consequences of aging and sarcopenia. Brad talked a little bit about sarcopenia and the use of squatting. I think that's a great technique. Unfortunately, one of the things, and Brad's a hypertrophy guy, what we've found with dynapnea is that, guess what? You can maintain your muscle size and have a significant resultant change in strength and function. Does that make sense? We can maintain our muscle size or even have a loss in muscle size, and there's a disproportionate change in muscular strength and power as we age. And that's a scary thing. That's a scary thing. I saw it in my parents. One of the most people who have had me in class, I pick on my parents all the time, but they were both pharmacists. I'm an exercise guy. I'm trying to get them active. Come to my gym, work out at my gym. Joshua Dega will tell you, down here, eventually they did. Josh was one of my personal trainers and strength coaches. My parents finally, guess what? They're in their 70s. When my mom came in, I did a little assessment with her to see where she was, and she did a squat for me. I just had her stand up against the wall and show me how she could squat. She got to what Brad classifies as 90 degrees, above parallel, and she couldn't control her body anymore and sank all the way down to her haunches. Good deep squat? Yes? Not an appropriate time, though. So anyway, very significant functional loss. So that's kind of where I am with how I move forward. There's so many people out there like my parents, right? They were dancers, and they did their walking. But as they aged, that wasn't enough of an impetus to prevent that functional loss. And I'm going to try to convince you that with resistance training we can do that, as well as reduce some of our cardiometabolic risk factors. And I'm just going to take a couple slides on that, and then I'll get to the prescription a little bit more. So we know sarcopenia is the age-related loss of mass. And then we talked a little bit about dynapnea. There's the reference, though, if you want to take a look at that. Manini and Clark, it's 2012. They're the people that actually coined the term dynapnea. So let's take a look at a little research. And I picked a couple studies coming out of the Cooper Clinic. This one had almost 4,000 participants in it, 3,000 men, 500 women. And they were evaluated between 1980 and 89 and had a follow-up 5 years later. And what is important with this study is they looked at low versus high levels of strength, and then they looked at functional impairments over the course of those 5 years. And they also looked at their ability to do a walking test on a treadmill. So why does that matter? What I want you to understand is the treadmill time. And across the top, you'll see high strength versus low strength for men. Same thing for women, high strength versus low strength. Look at the difference in the times. Significant difference between high and low for both men and women. Just in treadmill time, based on strength. And then I want you to look at functional problems over time. High strength, this is over 5 years. Those with the highest strength had 3 functional problems versus 8 for the low, 4 for the women versus 13. That's a significant difference. And the problems were anything heart attack, stroke, diabetes, high blood pressure, cancer, arthritis, and then functional limitations. That's a huge difference. And basically what the authors were saying is that we need a base level of strength even to participate in some of the activities that have the potential of changing or altering our fitness. For example, cardiovascular strength. So when you go to prescribe your exercise and you start with cardiovascular fitness as the optimal training tool to reduce risk, I'd ask you possibly to reconsider that. Resistance training may be the best starting point. It will allow them to do more on the other areas of their fitness assessment. Yeah?
When you're dealing with the seniors, I have two, and I've got to work around a ton of injuries. What I did was I did very basic resistance training, wall ups, wall plank, and then I spread the cardio to the next day.
Yeah.
Where they were rested. Do you
Yep.
split the cardio and resistance?
Absolutely. And again, as Brad would tell you, it depends. It depends on the functional capability of the people you're working with. It depends on how much time they have. It depends on how they recover from those bouts of exercise. So can you do it all in one day? Absolutely. Will they come in 5 days per week, 6 days per week to work with you? If they will, absolutely. Spread it out.
Well, doesn't that skew the readings, though? If you've given them a resistance and then you try and give them cardio, that cardio will be skewed because they're targeting the resistance.
Absolutely. But I will tell you this. And Bill Kramer just did a great lecture. Cardiovascular training only incorporates 10% of the muscle mass of your body. 10%. So maybe you should do it the other way around. If you're going to do cardiovascular training and strength training on concurrent days, maybe do your cardiovascular training on the first day, strength training on the second day, because you've only taxed 10% of your muscle mass. Then you come back and hit that 75 to 90% of your muscle mass that you hope to get with your resistance training program. And I'll get to an example of a program design as well. Okay, a couple more things. Syndrome X, this is the cardiometabolic consequence. You know, we all know what syndrome or metabolic syndrome is: abdominal adiposity, triglycerides, LDLs, hypertension, high fasting glucose. This is another study from the Cooper Clinic, looked at 3,000 men. And what I want you to understand is that across all age groups, strength was an excellent predictor of metabolic syndrome, regardless of age group. There's a linear trend. The weakest quartile had the highest risk for metabolic syndrome across all age groups. So what does that tell you? It has a significant protective effect on metabolic syndrome. So we need to get people stronger. Men at the highest strength category had a 34% lower risk of developing metabolic syndrome. It's pretty good. I would take a 34% reduction in my risk. And here's another study looking at 8,000 men. And what I want you to take away from in this slide is two things. We've got quartiles of strength and then tertiles of cardiovascular fitness. And what you will note is that there's an interactive effect between muscular strength and cardiovascular fitness, meaning that the highest fit individuals strength-wise and the highest fit individuals cardiovascular-wise had a mutually beneficial effect on reducing their risk of developing metabolic syndrome. Okay, so I'm not saying to eliminate cardiovascular training. Maybe start with resistance training and incorporate cardiovascular training because they have a mutually beneficial effect. Independent, but mutually beneficial, and that's important to know. So, and the other things, this was even among the most overweight and obese men. We need to replicate this study looking at females. All right? So some prescriptive guidelines. What did we find in that analysis? We found that the overarching finding for frequency was 2 to 3 days per week. 2 to 3 days per week. Is that a surprise to anyone in this room? No. No. 2 to 3 days per week. But I will tell you, go back 10, 15 years, we were advocating as minimal as 1 day per week of resistance training, and I'm sure all of you are shaking your head like, how is that possible? But that was some of the earlier guidelines. Looking at as few as 1 day per week can have a significant effect. But 2 to 3 days per week, probably separated with 48 hours of rest in between resistance training programs. Intensity. The largest group of evidence for the aging adult is high intensity. High intensity. We need to incorporate the ability to generate force in as small amount of time as possible. So when we're doing our resistance training programs, we don't want that 2 to 3 second concentric lift. We want that 1 second concentric lift. The ability to generate force in a very short amount of time is what's going to lead to the optimal benefits. Okay? And we have 6 to 15 repetition range, 8 to 12 repetition range, and I would say it's probably somewhere in that 8 to 15 repetition range. Can we go down? We're talking about strength. Can we go down a little bit more? Absolutely. Absolutely. Do I do 3RM bouts with my seniors? Yes, and I love it. But this is just a general guideline. Volume, how many sets? Thankfully, multiple sets had the strongest finding. But I will tell you that where do I start all my seniors? Single set. I'm the biggest proponent of multiple set resistance training, but I start all of my new clients, young, old, whatever, doesn't matter, on a single set. Why? I don't want them to be sore. I want them to feel good about that resistance training program unless they're a little, you know, whatever, they've got masochistic tendencies, right? But I want to be that person that's prescribing a program that's going to optimize the end result and keep them coming back, right? If we start our seniors off with too much volume, what's going to happen? They're going to get sore, they're not going to come back. Rest intervals. This was an interesting one. Anywhere between 1 and 5 minutes was the rest interval length. And I would put a caveat in here. How do you decide what rest interval length you should use? I would advocate the utilization of a rest interval that allows you to do the next exercise without undue fatigue based on the previous exercise. And then reduce that rest interval length if you want to work on more hypertrophic adaptations. And if you want to optimize more strength, a resultant strength gain, you're going to keep that moderate, probably a 3-minute rest period between sets, and possibly even between exercises. So we can't do one set of something, just like a circuit, and pop over to the next one and don't give them any rest time before we start that next exercise. They need adequate recovery time to increase those phosphocreatine stores to allow them to generate the force necessary for that next exercise. Yeah. If it's a unilateral exercise, you can definitely go from one side to the other. Good question. Okay, putting it into practice. Got about 5 minutes, so I'm just going to walk you briefly through this. I would advocate a warm-up, walking, cycling, whatever you want to do. And then do your version of a dynamic warm-up. Good, it's not me, it is a little hot in here. I typically don't get hot when I'm in front of people, but today I'm like, holy cow, what's going on? Menopause, something. Pick your dynamic warm-up. You guys are the professionals. You need to find something that gets every joint. And for my dynamic warm-up here, what I have, it's just joint range of motion. That's all we need to do. Why? Because they're pretty detrained. And I would venture a guess that when you work with some of these individuals, they're going to have range of motion issues. So your job is to get them adequately warmed up so the resistance training program can be effective. About 30 minutes, we can use light weights. You can use bands, body weight. If you have access to a fitness facility, all the better. But I would advocate maybe starting them without jumping them right into machines. In the design of my facility, I had a spare room that was all selectorized equipment in an appropriate manner where I could take people. It was much quieter. There wasn't the music. The light was wasn't as bright, and we could have one-on-one conversations so they felt comfortable. You need to find a way to get people comfortable with the program you're designing. Okay, 11 different exercises, a little bit of progression, and then make sure to vary your program. You can't do the same program forever. This is just one example. You're the expert. Can we incorporate BOSUs? Can we incorporate Swiss balls? Can we incorporate trapeze work? I don't know. What do you want to do? How are you going to vary the program to optimize their buy-in and constantly challenge the system? Most commonly we use volume and intensity, but I would argue it also needs to be programmatically. Here's the program. We'll just go through it. Calf exercise. Very simplistic. Double calf, single calf, bent calf. I read Cat in the Hat the other day to my wife's classroom, so it kind of brought me to the 1 cat, 2 cat, 3 cat, blue cat. Anyway, quadriceps exercise, short arc quad extensions, knee extensions, chair squat, regular squat, and lunges. How many variations of lunges do you know? 100? So can you come up with some variations in quadriceps exercises? Hamstring exercises, prone leg curl, standing leg curl, stiff leg deadlift. I love the stiff leg, Romanian deadlift, probably my most favorite exercise. Why? they will tell you the next day that they can feel it. I feel it. Hopefully you don't get to the point where they can't sit down, right? Because that does happen. You overdo it a little bit on your RDLs. But it's a great exercise. Very easy, and you don't need a lot of weight. In fact, you can do it basically with body weight because they haven't incorporated, they haven't had that glute activation that is so necessary for the movements. My dad's 6'6". I'm not sure what happened to me, but when he goes to sit down, he goes from here to about here, he controls it, and then what happens? Boom, right? So we need to find a way to encourage quad and hamstring and glute activation so that people can control their bodies in that space. Glute exercises, hip abduction, adduction, hip flexor exercises, abdominals, right? Planks. Planks. What do we typically do with our, even I did when I was in rehab, we did curl-ups, sit-ups. We didn't do planks. I love getting my dad into a plank position. It's like the one time in my life I can kind of cower over him, like, let's go, we're going for 2 minutes, right? But it's a great exercise, and they can see instantaneous progression in their capability of doing the exercise. Wall push-up, here's your exercise, right? Wall push-ups, chest press, bench press, modified push-ups. Get them controlling their body in space. Mid-back exercises, scapular wall slide, one-arm dumbbell rows, I's, Y's, W's, T's, whatever you want. Get that mid-back activation as well. Good scapular movement, good shoulder, glenohumeral movement, good scapular thoracic movement as well. Bicep curl, tricep kick back. Still got to do them. My dad still wants the guns, right? Shoulder scaption, shoulder abduction, shoulder press, bicep curl with the shoulder press. I love complex exercises. Pick an assessment tool. Here's the AFERT assessment tool. Flexibility, agility, dynamic balance, coordination, strength, muscular endurance, and power. Let me show you just briefly what they are, and then I'll quit with this. Sit and reach test, agility and dynamic balance test. How many of you do a fitness assessment with your aging adults? Get them started, do a fitness assessment. Excellent if you're doing it. Monitor it over time, manipulate your program based on the outcomes. Agility, dynamic balance, bicep curl, pick your strength measure, an 800-yard walk. Track your assessment, and then reevaluate the evidence. Has anything changed over the course of your program? Has anything changed over the course of the time? As I state, I'd imagine that's why you're here. You're looking for new evidence. You're looking for new information. So, final thoughts. There is an inherent need for progression and periodization in our resistance training program if we want continued improvement in our resultant strength gains. So our resistance training program is dependent on the goals. We utilize the evidence and our personal experience to guide that resistance training exercise prescription. And finally, there is no one right resistance training exercise prescription. Right? There isn't. If anybody tells you they've got it, they're full of it, right? But use the best evidence science to base your programming. Thank you, and I will stick around outside and take any questions that you have.